Okay, so this is the lecture for week two of anesthesia. This chapter covers special techniques. In the book, it is local anesthetic techniques and ventilation. I think when I printed your notes, I left off the notes about ventilation. They may still be in here, but it'll only cover up till local anesthetic techniques. Ventilation I'll add to a different lecture. And then the next video will be chapter 8, which is the opioids. The other thing to mention is the homework sheet for this chapter, which is shorter, is due Friday. The longer homework sheet that goes with chapter 8 will be due on Monday. And then Monday, between Friday and Monday, I hope to review both sections. And then Monday afternoon, the test will open just like it did. And hopefully I get those tests graded soon. So let's talk about what it means for special techniques. And basically, we're talking about local anesthesia, which is a broad term. And this is when we use an agent on typically the sensory nerves. And what we're trying to do is prevent transmission of the pain. And then there will be a loss of sensation. So if we need to help with restraint, if general anesthesia is a risk, if we can't do general anesthesia, or just to enhance analgesia. These are all indications that why would we use local anesthesia. For example, when you go to the dentist, okay, not everybody gets anesthetized. And basically, they will block your nerves and fill a cavity. So they will give you an injection of a local anesthetic. And then that anesthetic is going to disrupt transmission of the painful impulse. So it stops, so you never feel pain because the brain never has the ability to detect that there was a painful impulse. Now, there are times that we will anesthetize an animal, pre-meds, general anesthesia, isoflurane, and we will use a local because if we block them sensing pain, we're going to be able to use a lot less anesthetic. So local anesthesia also has an anesthetic sparing effect. So you can use it with general anesthetics, without general anesthetics. And it's definitely good in terms when you can't use general anesthesia. So the advantage is that generally these drugs as a category do not have cardiovascular toxicity, but I do want you to know cats are particularly sensitive to lidocaine. So our dose in a cat is going to be much lower than it would be mg per kg in a dog, a horse, a goat, whichever. Cats do have a sensitivity to these drugs. The other thing is they are cheap. Lidocaine is dirt cheap. I'll talk about the other drug. Obviously, as the drugs improve and they make new ones, they do become more expensive. But lidocaine is our gold standard that's been around for a long time. It's very cheap. And then obviously good pain control, and it helps minimize recovery. Now, I do talk about small animals more, but local anesthesia is used heavily when we get into, it says ruminant obstetrics. So a cow C-section is a standing procedure. They will numb the lateral abdomen of the cow, and that will be numb, and they can stand there. They don't lose their strength in their legs. Sometimes they'll give them a little sedative on top, but most of the time they're standing awake. In horses, we can give them sedation and give them a local to help do a joint exam, do a laceration repair. And then a lot of times in small animal, we use them in additional for pain control. And I'm going to talk about some indications, some procedures when we would use local anesthesia. So the drugs that typically are available, and these would be, you can put them under the skin. That's what infiltration means, to inject and infiltrate. We can also put them on mucous membranes. If you've ever been to the dentist and they put that little Q-tip of the gel and sometimes they stick it in your gums and they wait, and then they come back and give you the injection. That would be like a mucous membrane or a topical application. But then they come back and they infiltrate or they inject it. So sometimes they're used together. The gold standard is lidocaine, which I want you to know is cheap. It comes as different concentrations. So 2% is probably our average or standard amount, but you can get it in 0.5%. So again, when you calculate this and you order this, I always say, because technicians, a lot of times, you're the one in charge of ordering for the practice. You want to make sure they sent you the proper concentration. You can dilute it in saline if you need to put a bigger volume in, but you don't want to increase the amount of drug. You can dilute it. But I want you to know lidocaine is cheap, but what it does, it kicks in faster, but it does not last as long. So you need to add that to slide 4. Bupivacaine, and this one we tend to use more in like our advanced procedures, sterile procedures. Bupivacaine comes as a 0.25 or 0.5%. This is more expensive. So it's a little more expensive. It takes a little longer to kick in, but it's going to give you a much longer duration. So that's going to be the advantage. Procaine, proparacaine drops can be used, and bupivacaine is another injectable, but the two main ones that I want you to know are lidocaine, bupivacaine. Now, if you end up working, most clinics will do some of their own eye exams, or if you work with like an ophthalmologist, we will use tetracaine, but most of the time we use proparacaine. I helped out in ophtho when I was at VCA, and if we were going to do an ophthalmic exam, what I would do is I'd go in the lobby and I would put in the proparacaine drops, and then I would talk to the owner, fill out the forms. So the whole time the eyes are becoming numb because we were doing ocular pressures. We were doing a much more advanced ocular exam. You don't have to numb the eyes for every procedure. But proparacaine drops can also be used to numb the nostrils if you're placing feeding tubes or nasal oxygen. When I used to teach Animal Tech 6, there's a slide and it shows the drops. And what I do is I drop them in the nasal cavity, wait 5-10 minutes, set up my supplies, and then by the time I come back, hopefully the nasal cavity, at least the, more of the rostral part would be numb, and then I can hopefully pass the tube. So these first 2 or 4 here are injectable. These are the 2 most common, and then these would be like an ophthalmic preparation. So when I talk about characteristics, what do we know about them? They are not general anesthetics. This is considered an adjunct technique. We have an anesthetic protocol, pre-meds, induction, maintenance. This would be added to that. Does it have to be done? No. But it's going to enhance our anesthetic event. So it does not affect the brain. It does not have a sedative effect. In rare cases, we do give them IV. So if you do use these agents IV, it can cause some sedation, but for the most part, we usually inject them like under the skin, on a wound, in the muscle, in a joint. Very rarely do we go IV. The nice thing is they do not have very many cardio or respiratory effects because it's not going to the systemic circulation. They are not CNS depressant unless you are giving them IV. So if we want to minimize doses in like a high-risk patient and we use these, I know it's not going to make the side effects of our pre-meds worse. Where they act is usually where you give them. So they have their action locally, not systemically. If you give it IV, the effects can go to the whole body. That's what systemic means. If I'm going local infiltration, then if I inject it, at your teeth, we're blocking these teeth right here. The doctor doesn't need to block, your cavities over here. So they're not going to block over here. Now, sometimes we will block a whole region. I'd have 2 teeth worked on the same jaw, and they blocked like the whole nerve root. Sometimes we give it right under a wound, and you're just going to block right there. And when you give these in IM sub-Q, they don't typically cross the placenta. By the time the drug you give gets into circulation, it's become watered down. It starts to disappear. So, excuse me one moment. Okay, so I ended off with they don't normally cross the placenta. The small amount that does get metabolized shouldn't create much of an effect unless you give it IV. But this is very important to understand. How do they work? Primarily, the main thing we're doing is we are trying to block the sensory nerves. If you remember, like I've used this analogy in class, I burn my hand, sensory nerves pick that up, they send a signal to the brain, my brain senses the pain, sends a motor response to a motor nerve, and the motor nerve moves my hand. What we're doing here is if you place it close enough to the neuron, and you have to get it under the skin typically, I mean, you can also put it locally, but what is happening is it's blocking the sodium channels at that neuron. And what you're doing, if you remember, sodium channels have to open to allow the nerve impulse to depolarize. And the waves of depolarization is what sends it to the brain. Well, if you block those channels from opening, then the nerve impulse cannot send. So therefore, the brain does not detect that a painful event has occurred. So you're technically blocking the generation of that electrical impulse, which is depolarization. It stops it. Now, what happens is that drug is sitting in the skin here, say you block here, eventually it's going to be removed from circulation, it's going to be removed from the tissues. So gradually that area is going to develop a sensitivity. Now I'm going to talk more about how we have to use other pain techniques, because the local anesthetic, lidocaine might buy us like an hour or so. Bupivacaine could be longer, but these are never really the only drugs we use, because like I said, eventually sensation is going to come back to that area. And what happens is the drug is removed from circulation. It basically will go to the liver to be cleared. So there is some liver metabolism, although it's not a large amount. Now, some drugs will actually affect the motor neurons. When we get into bupivacaine and when we talk about regional blocks and you're blocking a large area of nerves, you can get some paresis, which is like a decrease in sensation, or actual paralysis where they cannot use their legs. Now, for example, when we do a C-section in a cow, we do not want paresis or paralysis because the cow needs to remain standing and the cow needs to be able to walk. Sometimes when we use epidurals in dogs, sometimes that evening they stand up and they're very wobbly. Sometimes they cannot stand at all till like the next morning. We have to help them outside. We have to make sure they don't soil themselves. So motor nerves are typically blocked when we do more of these regional, larger blocks, and they are affecting nerves that control limbs. A C-section block is blocking the abdomen. It is not blocking the forelimb and the hind limb, but where you put an epidural, it affects the hind limb nerves. Therefore, we can get that weakness / paralysis. And again, that's fine. Those dogs are typically in the intensive care. We can clean them. We can help get them outside. It's not typically going to last more than 24 hours if the dog can't walk that night. It would be a very rare occurrence if the next day the dog could still not walk. Okay, so these drugs do affect the autonomic nervous system because that's what conducts the impulses. So some of the not desirable or things that can happen when we use these drugs is if it does affect the sympathetic neurons in the brain and the blood vessels. Now, most of the time, because we're giving them locally and we're giving appropriate doses, we hope to not get to the level where it affects the brain and the interaction between the organs. Sometimes we can get what's called sympathetic blockade, Remember, the sympathetic is your fight and flight. I want to block nerves. I don't want to necessarily block the actions of the sympathetic system. Again, sometimes this is due to how we give it or where we give it. If now this is important to understand, it says sympathetic blockade may affect the heart if local anesthetic diffuses into the thoracic spinal cord. You have to remember anatomy. When you give it epidurally, which is near the tail, and you push the drug, you are pushing it around the spinal cord. We are not giving it in the spinal cord. We are putting drug around the caudal end of the spinal cord. But if you give too much drug and you push it too fast, you can push drug past the lumbar spinal cord and it can block the nerves of the thoracic spinal cord. If it does that, it can affect the heart. So we have to be very cautious when we do epidurals. We don't push it too fast. We have a defined amount that we calculate. But again, if you push too much or too forward, it can affect the thoracic nerves. It can also affect the nerves in the animal being able to respirate because those nerves control those muscles of the thoracic wall. So hopefully you understand what I'm saying. We have to be careful. Sometimes when we give these drugs, any animal can have a reaction. It's rare, but if you start to see like local flushing, the skin starts to look red and injected, or you feel the skin and it feels hot, which is abnormal under anesthesia, it can lead to some vasodilation. Those are signs of there's possibly a reaction happening. And if we get massive vasodilation, which usually happens from a reaction, vasodilation is going to lead to a hypotension, which is a drop in blood pressure. So all of these are things that can happen. They are not typical. Most of your local anesthetics are safe. We're giving them in safe locations and safe amounts, but these are things that we need to watch for. Okay, so those are some of the, I wouldn't necessarily say those are side effects, but those are things that can happen when we use those. So let's talk about the different ways that we can give them. One of the first routes of administration is a topical administration. You're putting it on top of something. So this is typically intact skin. Most of these drugs that are prepared this way can actually, now it has to penetrate the epidermis, which is the top layer, and then it has to get to the dermis. That's where the nerve endings are in the blood supply. So these drugs diffuse through the epidermis to the dermis. And the only downside to topical, you get less pain relief. They're not as strong, and they don't last as long. If you want it to last longer, you're better doing the injection technique versus just dropping something on top or putting it on top. So there is some ethyl chloride spray. Now, a lot of these we don't typically use. Emla cream is something, we did have this when I was at Purdue. They use this in infants and pediatrics. It's a little bit of cream. So sometimes when they have to put catheters in babies, they'll rub this cream over the site of where they're going to inject, and it'll numb the area. We tried it. The difference is the thickness of skin in animals. It's not predictable. That's the other issue with topicals. We're dealing with fur. A Shar-Pei skin versus a Lhasa skin. But Shar-Pei skin is very thick versus a Lhasa, or a poodle has a little bit thinner skin. So there's a difference there. One thing that we do is something called a splash block. Now, I've told this story before where I had a Great Dane come into the ER. He had ran around a pool bracket, sliced open, missed the jugular, but sliced open the shoulder blade, and we could almost see down to the shoulder and the scapula. What the doctor did, we were cleaning it, and after we cleaned it, she just took lidocaine from the bottle, but instead of putting a needle in the muscle, she just squirted it all over the muscles, and that's called a splash block. So if we splash it into a wound, if we splash it that way, it works like that. It blocks, but that's really blocking the surface of those nerve endings, it's not getting the deeper. So, I mean, it's not like that dog is not going to feel anything. It was just something to enhance analgesia. The other thing we can do is when we have thoracic trauma, we have a hit by car and they have like fractured ribs, or if we did thoracic surgery, that animal always got a chest tube, and that's so that we could suck the air out of the chest and create the negative chest. But what would we do after surgery is we would take bupivacaine because it lasts longer and it's typically preservative free. I forgot to mention that. We would inject it in the chest tube. So yes, we were putting injectable fluid in the chest, but we would put it in and then we would take the patient and roll them. And what we were doing is we were bathing the chest cavity in this bupivacaine to hopefully give some pain relief to the chest cavity. Okay, it's not going in the lungs, it's going around the lungs, and it's not going to affect breathing. We're just trying to numb the pleura, which is the lining of the thoracic cavity. Now, mucous membrane application, people, like I said, get that at the dentist, a little gel. There's lidocaine rinse if you have, like, people that have dental work. We also use them sometimes for cats that get the really bad ulcerated gums. We used it for dogs with oral cancer. There's a rinse that we could get lidocaine, and the owner could squirt it in the mouth to hopefully get some relief. There's also lidocaine spray, which you could use, or patches. Now, people, they use lidocaine patches more in people. My friend had back surgery, and they put 2 long patches. So if this is his incision, they put 2 patches right next to the incision, and that would release lidocaine slowly over time. And I'm going to talk about fentanyl patches when we get into opioids in the next chapter. But they do make lidocaine patches. We had some at Northwood when I worked there, but they use those in people. So all of those are topical. I want you to, for every technique, I want you to give me an example or be able to tell me an example of what's an example of a local, a topical administration. That would also be eye drops too. I didn't put that on there, but eye drops are a topical infiltration. Okay. Now, if we're going to do local infiltration, this is when we put it in a syringe and we inject with a needle. And what we're doing is we're trying to target nerves in a specific area, not large nerves, but more of your superficial nerves. Now, I talked about plain lidocaine, but I want to stress a topic that you need to understand because it is a question on the homework. You can get lidocaine that has epinephrine. Excuse me one second, because the puppy is going. Okay, you can get lidocaine by itself. They also sell lidocaine with epinephrine added. Epinephrine, if you remember, causes vasoconstriction. It's why we use it in emergency, to cause vasoconstriction, to increase blood pressure. If I take lidocaine and I add epinephrine, you are not putting it in a vein. You are putting it in the skin, inside the skin around a nerve. What epinephrine does is it shrinks the vessels in that area, and it will slow down the absorption of the lidocaine. So hopefully that makes sense. If I take my vessel from this size to this size, it's going to take longer to absorb that drug. So epinephrine is added, and I definitely want to ask this question, why do I put epinephrine with lidocaine? You do it to delay absorption, to increase the amount of time lidocaine will be effective. So again, you can do plain lidocaine. You can drop lidocaine and epinephrine, but they do make a lidocaine that comes with epinephrine in it. Okay. Now, this could be intradermal in the skin, sub-Q, IM. This isn't typically IV. Okay. One thing that I will stress, and I don't think it's in the PowerPoint, whenever you inject, and you're trained to do this, whenever you go to give an injection, wherever, you're supposed to pull back and look for blood. If you go to inject the skin in an area, you shouldn't get blood back unless you're trying to hit a vein, and that's IV. But if you're going any other route, If you pull back and get blood, you have to pull out, get a new needle, and start over. Okay, so you're only trying to give this in the tissues, the muscles, and what this does is it gives you that superficial pain relief. Again, we're not blocking large trunks of nerves. We're blocking the smaller, like peripheral nerves, the sensory nerves. Usually clean the area, and most of the time these are done, I know it says 20 gauge, that would be like maybe a horse or a cow or something, but normally small animal would be like 22, usually 25 gauge needle. The amount of drug will depend, and also the location, but I want you to put a note by the amount of drug, because every time you work with local anesthetics, you need to calculate your patient's maximum dose. Every patient is going to have a maximum amount of lidocaine you can use. In cats, I want to say the average 10-pound cat shouldn't get more than 2 mils total. So that means if you're going to block a leg, you cannot give that cat more than 2 mils. Now, obviously, like I said, a dog, a horse, a cow, they're not as sensitive as a cat is. So you're going to probably have much larger volumes. But I always know somewhere in the patient record what is the and I don't usually start by drawing up the maximum amount, but you always want to know, because if you have to inject more and more, like when I go to the dentist, maybe this is not really TMI, but I told the dentist one time, I go, I get maximum level blocking. First of all, I have fear of the dentist. And second, I just know it takes a lot. They ended up injecting me 3 times for some dental work. And she was like, yeah, you're at your max volume. Like I knew I couldn't get more because they've given me as much as they can give me. So every species is going to have a maximum amount of lidocaine. So when they gave me 3 injections, it added, if it's 20 mils for a patient, you might give 5 mils, 5 mils, 5 mils, and you have 5 mils left over. But you're never going to go over 20 mils, if that makes sense. Now, how do we know when you say you block an area? Well, like when you go to the dentist, I'm going to keep using the dentist as an example. They usually will kind of like poke your gums, or they'll poke your tooth and say, do you feel that? And you'll tell them, now, I can say yes or no. If I have a dog, how do I know it's effective? Well, you might touch the leg. Do they move it? If they're anesthetized, does their heart rate go up? Does their respiration go up? So in an animal, it's a similar theory. You want to try and test the area before you start, but how are we going to do that? How do I know? Because like I said, they can't be like us and go, They have to show us in other ways. Okay, so each area should be tested. Now, this can be an effective technique. It depends on where you're giving it. If you're going intradermal, your goal is blocking really the skin, the upper skin. You're not talking about getting into the deep tissues unless you go IM. The only downside that will sometimes affect how well they work, if you're treating a wound that has healed and there's scar tissue. If you remember, scars do not have a lot of blood supply. And the problem is that skin is usually tighter and more dense. So if there's a lot of fibrous or scar tissue, fat, it's because of the water solubility versus fat. That's not going to absorb well. Also, if you say this wound is like bleeding a bunch, like the surgery, and you're putting it in and that blood is just pushing out the drug. So if there's a lot of hemorrhage, fat, scar tissue, those are things that are going to affect how effective our agent is. Okay. And then again, how long do they last? I want to say, like I said, lidocaine's about an hour or so. Bupivacaine can be, I want to say I've read 4 to 24 hours. Bupivacaine can be quite long. So how long, it depends on what drug, and then how fast is it being absorbed. Remember, epinephrine is going to delay absorption. So anything with epinephrine is always going to last longer than if you just give the drug by itself. Okay. Um, the other thing, now I know sometimes when you guys read these PowerPoints, you can see the note. It said local anesthetics with epi should not be administered intravenously. Absolutely, because if you're ever using epi, that's going to affect vasoconstriction in your blood vessels. When you give epi around a wound, hopefully you don't accidentally give it in the vein. But when you're using epi, absolutely, absolutely, absolutely make sure that you are not in a blood vessel. Okay? Never want to do that. So it says, sometimes they say doctors don't like to use the epi blocks in the limbs because it can affect circulation to the limb. But I know sometimes they use the epi with horses to give them longer pain relief. A lot of times you'll do joint blocks in horses for pain relief, and that's a good thing. Okay. Now what we're doing here, we've gone from just squirting it on the tissues, we've gone into infiltrating it in a small area. Now we're going to actually try to block nerves. And what we're talking about is we're talking about nerve roots. And we're trying to get this to a nerve. And what we do with nerve blocks versus infiltration is we're trying to block an anatomic site. We're trying to block a fairly larger area. And the whole reason we do nerve blocks is to decrease the amount of anesthetic. I will say, when you guys are in surgery rotation, I think you guys at the end on cadavers, I think you practice some dental blocks, because there's a lot of advanced practices that are doing dental blocks for extractions. Think about it, your patient, even though they're anesthetized, they're not going to feel the extraction. But if you do a local block on top of general anesthesia, that patient is going to have much better pain relief than if you just did anesthesia alone. So the nice thing is too, these nerve blocks will last longer and can hopefully give you some post-op analgesia. Again, it's not going to last for hours and for days, but that immediate post-op period, like that evening, should help the patient recover better, feel better in the evening. So let's get into nerve block techniques. And these are examples. And again, I told you, if I said, what are some situations we would do a nerve block? And remember, this is talking about a region and an anatomical region. Dental blocks, blocking a jaw, blocking a dental arcade. When we do thoracic surgery, we will inject bupivacaine between the ribs, and then we do the incision. Amputations, absolutely. When we do a limb amputation, we will block the nerve talking about the brachial nerve that comes to the forelimb. The doctor will actually put in bupivacaine into that nerve and then wait 10 minutes, and then he cuts it, because there's something called phantom pain. People talk about it that lost a limb. They feel like the limb is still there. If you block the local nerve, you decrease the chance of phantom pain. So it's one thing. Again, a dog can't tell me, hey, is my leg still there? So, but people can describe the feeling like, where is my limb? Another big area, I know declaws are kind of going by the wayside, but a more advanced practice, which they do something called a ring block, and they will put it in the nerves. And excuse me. Okay, sorry, dogs. So I was talking about cat declaws. You can block the nerves that control the paw. So when you take the digits, no pain. One of the big nerve blocks we do, it's called a paravertebral block, or sometimes called an inverted L. And what we do is we block the nerves that are controlling the flank, and then the doctor makes an incision in the abdomen. There's a picture coming up. Or the corneal blocks for dehorning. So they will block the nerves that control the horn buds. And then in horses, they will do for lameness exams in horses. So if you have a horse that's running and you can kind of see they're limping, A lot of times doctors will block the nerves in that area, and then all of a sudden the horse will run normal. And that kind of determines which joint is affected or which joint is causing pain in the horse. So nerve blocks can help identify joint issues because then the horse actually runs normal. Now that doesn't last, you still have to fix the issue, but it helps determine which area of the horse is lame. Now, the other way we can do this technique is something called a line block. And it literally means you're putting anesthetic down a line. If we do a ring block can be for a declaw. You can put a ring around a teat. So sometimes cows will get a tear in their mammary gland. You can put around a ring around a teat, and you can get injury to that. Sometimes, and then what we do with cattle is this is the L block. Now see how that looks like an inverted L? So this is called a paravertebral, para near the vertebral area. So what we do is you can see the nerve roots of L3, L4, L2, L1. So here's the last rib, okay? See how what they'll do is they'll block these roots. So they infiltrate lidocaine here and here. And then what it does, they will make the incision in this little red square. But you can see all the nerves controlling that area are blocked. And that's how they will do the C-section. Now you can also do just a line and block just these nerves, but the L takes a little bit longer to do, but this is a line. I will also, and this is something technicians can do, but usually before a C-section in dogs, right before the surgeon comes in, I put a line of lidocaine. I just inject under the skin, squirt a little bit, go down, squirt a little bit. It almost makes like a dotted line. And when the doctor comes in to cut through, we can use less anesthetic during a C-section. So a lot of C-sections, we will do a line block down the abdomen, and that will, again, it doesn't go to the pups, and it enhances analgesia, so I don't use as much general anesthesia in the mother. Okay, so some other reasons or other ways we can give this. We can go something called intra-articular. Remember, articular means joint. So you can actually inject, usually we're going to use bupivacaine or mepivacaine because those are the preservative-free and they last longer. So you can put this in the stifle. We can put this in the shoulder. So you can use it in any joint to enhance analgesia, or like in horses for lameness exams. Now, if we're going to talk about a region, we're usually talking about blocking a trunk that has more roots. So, for example, if we put it in a nerve plexus or near the spinal cord, then you're going to block a larger area. For example, if you remember when we did dissection, a lot of times I had you guys dissect, it's called the brachial plexus. So if you cut into the armpit, there is a major trunk that exits to the brachial nerve, the antebrachial nerve. It'll block, if you put lidocaine right in this root, you're going to block all those nerves. You're blocking a region. You're blocking the forelimb. You're not just blocking the nerve here, you're blocking the trunk. And that is called a brachial plexus block. Now, the paravertebral block that we just talked about, this is only in cattle. They don't do it in pigs or horses or dogs. It's for a standing laparotomy. A laparotomy is basically opening the abdomen, like an abdominal exploratory. So anytime you open the abdomen, it's called a laparotomy. So you will do a laparotomy is technically for a spay, for an abdominal exploratory, a splenectomy, a C-section. Those are all done via laparotomy. So laparotomy is a very broad word, just saying we're cutting into the abdomen for some reason. So you can do paravertebral versus the L block is a technique, and this gives us a much wider block. The only downside you have to be cautious is is sometimes it can cause some hind limb weakness. We wouldn't worry about scoliosis right now. I just know that when you do this technique, it can cause that weakness. And remember, we don't want the cow to go down, because cows that go down, or if they can't get up, they are going to start to, it compromises blood supply to the limbs. I mean, they can potentially be euthanized if you cannot get them back up. So it's very critical in ruminants and even horses too. But when we do these techniques, we want to try to keep them standing. They're going to do much better if we can keep them standing up. Much better for the patient. Okay, I had to put a fair amount of questions on your homework regarding epidural anesthesia, because this is something that we can do in small animal. Now, I will tell you, when I was at Purdue, the technicians in anesthesia were trained to give epidurals. A technician can do an epidural. Does not have to be a doctor. Now, you can always work for a doctor that's very particular. And some doctors are like, I'm the only one giving my epidural. But it is a technician can be trained. That would be like an on-the-job trained thing. We would never hire someone and be like, don't you know how to give an epidural? I would expect you to know where it is and why we do it, but how to do it, you would go through that training. But this is a regional block. You're blocking the epidural. Epi means above, dura. Dura mater is the spinal cord. So we're giving it above the spinal cord. We're not giving it in the spinal cord. That's very important. But what this will do is it blocks sensation and motor. Remember, some blocks just block sensory nerves. This blocks both. So we don't get sensation going up, so we don't feel the pain, but also it can affect the degree of paralysis to that area. So these are good for anything that's near the abdomen, pelvis, perineum. So a tail amputation, like especially if you have say there was a hit by car, a dog got his tail crushed in the garage, and it's mangled. You could do an epidural and it'll numb the whole tail. Very anal sac surgery. Perianal, anything around the anal gland area that's painful. Urethrostomy, if we have to cut into the urethra. C-sections. Obstetric manipulations. Do you have to pull out a calf? If you do an epidural, it may relax the muscles, make that easier. Now, I will know when I was at Purdue, almost all of our stifle surgeries, hip surgeries, some stifle surgeries would get an epidural. So like a stifle surgery is a rear limb operation. There was a surgeon, he wanted every stifle surgery of his to get an epidural. So we got fairly good at doing these. So be able to tell me some indications for giving an epidural. Okay, so as long as you can tell me some choices that we would do this. Now, another important way, something to understand, when we do those line blocks and when we do those paravertebral blocks and dental blocks, we are typically only using lidocaine or bupivacaine. We usually just use a straight local anesthetic. When we do epidurals, we tend to mix different agents in. Now, you can totally do it just the lidocaine or bupivacaine by itself. I have had doctors give just a morphine epidural. Morphine, which we normally give as a pre-med for pain, if you give it in the epidural space, it will actually have analgesic effects. So it could just be a morphine epidural. Sometimes we will do morphine and lidocaine, or morphine and bupivacaine together. And there are reports of large animal vets using opioid and an alpha-2 because the dextrometor, the xylazine, can have an effect at the epidural space. So with an epidural, it is not just, if I said on a test, what else can you use for an epidural besides a local anesthetic? You could tell me morphine, alpha-2s, drugs like that. Now, this area we give it, there is this very specific point, and We always have to be cautious, but I don't want you to be nervous. What we're trying to do is put it in the epidural space. If you remember, there's vertebrae, there's a space for spinal fluid, and then there's the spinal cord. What you're trying to do is you're going to pop through a ligament, and then there's a space, and then the spinal cord would be there. But when we do this, we are giving it at L7S1. L7S1, which is the last lumbar vertebrae and the first sacral vertebrae. If I've not stressed this in anatomy before, the spinal cord, when it starts to get to like L5, it starts to narrow. By the time it gets to 6 and 7, it's pretty much stopped. There is no spinal cord in the tail, okay? So when you give, or in the sacrum, so when you give it at L7S1, technically the cord is like, the end of the cord is up here. So you shouldn't really be able to get it in the cord, but the very end of the cord is there. It's kind of, so it's kind of just depends, but the cord is going to be ending about that point. Now, if you were to put it in and kind of point forward, you could potentially hit the spinal cord. So we usually put it like straight up and down, but it's between L7 and S1. And there are pictures, the whole procedure is written in your book if you do the reading, and you can see the pictures and how they position the patient. So I do want you to look at that. The nice thing is we get the blocks, sensory and motor. The only thing that we have to be cautious of, it can affect the tail. Well, if they can't wag their tail, they can't wag their tail, but it can affect the rear limbs. So if we want them walking, that'd be another reason to just do a morphine epidural versus bupivacaine, because morphine is not going to, it's just going to treat the sensory pain. It's not going to numb or make them not able to use their legs. So if they were affected, morphine tends to not affect the motor nerves as much as like lidocaine or bupivacaine. So again, the benefits to giving those, the things we have to watch for. But, some of our students have gone to work at VCA. Some of our students work in the intensive care unit, and they work overnight. Their job is to watch all the patients after surgery. If you have a patient that's had an epidural, we usually have to take them out 2 or 3 times in the evening. Are they going to be able to get up? Do I have to sling walk them? Do I have to make sure they're not laying in their urine? I have to also make sure to flip the patient, because if they are laying on one side and they can't use their back legs, I may have to help them turn over. Because I didn't talk about this in recovery, but a patient should only lay on one side for 4 hours. If I go by a cage at 8 p.m. and the dog is in right lateral recumbency, at midnight, they're still in right lateral recumbency, I need to turn that patient over. And then at 4 a.m., turn them back over. And then 8 a.m., turn them back over. So that's the consequence if they can't use their limb. Okay, you don't need to know the beer block technique. And you don't have to know the continuous rate infusion. So you don't need to know those two. Now, what are some of the adverse effects? Because nothing is perfect. So the degree of motor loss can be, now again, if they can't use their legs that night, that's not, or they're weak, that's not out of the ordinary. But if it was continuing into days and days, that would be an adverse effect. If we have nerve function, a loss of nerve function multiple days later, did we damage a nerve doing a block? Paresthesia, which we're going to get a heightened sensation in that area rather than numbing. We can get allergic reactions all the way to like anaphylactic shock. I think I'd already talked about it, but if you look at an area and it's very red and inflamed and hot, maybe they had a reaction to it. Occasionally you can get toxicities if you give too much, if you miscalculate. If you gave it in the vein instead of in the muscle or the skin, we can get into systemic toxicity, especially in cats. So we have to be very cautious. Remember, every animal is going to have a maximum local anesthetic dose. And I always know that number. So if my doctor keeps asking for syringes of local anesthetic, and I'm like, the max dose is 40 mils, if I hand you the last syringe, I'm like, that's our patient's max. If you go over that dose, you have a higher chance of having these toxicities. Now, you can get trauma to the spinal cord, cauda equina, if we that back area, potentially if you inject improperly. But again, I've done this. I did this for a lot of patients and was able to do it safely without having any issues. So as long as you're palpating, like I said, the technique I want you to review, it's in your book. I'll try to find a video, but it's all written out. Now, one thing to be very cautious, you can get toxicity, potentially even death, if we put too much drug in and it migrates to the spinal cord. Usually I only worry about this happening when you're doing it epidurally. Like I said, when I push it, I push a fairly consistent, and I push it pretty slowly, because then as you push it, it has less of a chance to migrate to the thoracic spinal cord and cause any paralysis of the thoracic muscles. Or affect the heart. If you get into the cervical or thoracic spinal cord, you can block the sympathetic nerves, and then we wouldn't have a patient that could use the sympathetic nervous system to maintain blood pressure, maintain heart rate, so we can get the bradycardia, we can get low blood pressure, and we can potentially get this anaphylaxis. So these are the downsides, but many benefits. That's the rest of it. Again, this didn't delete from the version I emailed you. Hopefully it isn't in your notes, but anything past slide 26, I'm going to talk about when we talk about horses. I'll talk about ventilation. All that's going to be on this test is going to be these local anesthetic techniques and these drugs. So don't forget to do your reading. This homework sheet will be due Friday. We'll review this. I will send out this video, and later this evening, I will record the second video for Chapter 8, and that will come out separately. And of course, I will say this on the video. Hopefully you've listened to the end. I know I'm not doing a live Zoom this week, but if you have questions, if you want to meet like this, it's very easy for me to set up a Zoom, email you a link, and I'm willing to meet with you. I just know we review Friday, so I thought, well, what am I going to talk about today that I'm not going to talk about on Friday? But again, if you want to email me, set up a Zoom, I'm more than willing to do that. So I will see you guys with the next video, hopefully very soon.